Hello everyone, this is Dr. Mahmoud, and in this lecture we're going to talk about the high-yield spinal cord lesions that you can get asked about on your exam. So get a pen and paper, get your coffee ready, and let's get started. So there are 9 main spinal cord lesions that you can get asked about on your USMLE exam. In this lecture, we're going to talk about the first 4, and in the next lecture, we're going to talk about the other 5. The 4 spinal cord lesions we're going to talk about today are the Brown-Sequard syndrome, poliomyelitis, spinal muscular atrophy type 1, aka the Werdnig Hoffman disease, and the tabes dorsalis. So if you like the content, don't forget to like and subscribe, and let's get started with the first spinal cord lesion, the Brown-Sequard syndrome. The Brown-Sequard syndrome is caused by a damage to one half of the spinal cord or a hemisection of the spinal cord. It can occur due to a tumor compressing on one side of the spinal cord or due to trauma, such as a penetrating knife or a gunshot. Now, the presentation of the Brown-Sequard syndrome will have to do with what we explained in the previous 3 lectures. So if you haven't watched them, make sure to check them out. The patient will present with some findings at the same level of the spinal cord lesion and other findings below the level of the spinal cord lesion. At the level of the spinal cord lesion, the patient will have loss of all sensations on the same side of the damaged half of the spinal cord, and a lower motor neuron lesion of the muscles supplied by the affected segment. And as we remember from previous lectures, the lower motor neuron lesion presents with hypotonia, hyporeflexia, and flaccidity. The spinothalamic tract will be damaged, so there will be a loss of pain and temperature. The dorsal column will be damaged, so there will be a loss of pressure, vibration, proprioception, and fine touch, and the corticospinal tract will be damaged, which will present as a lower motor neuron lesion at the level of the lesion. On the other hand, the presentation of the Brown-Sequard syndrome below the level of the lesion will present with a loss of all sensations on the ipsilateral side or on the same side of the lesion, with the exception of pain and temperature. Because as we can remember from previous lectures, the spinothalamic tract, which is responsible for pain and temperature, decussates or crosses to the opposite side shortly after entering the spinal cord. So a lesion in the spinothalamic tract will present contralaterally below the level of the lesion. The other sensory tracts, however, decussate upwards at the caudal medulla. As for motor affection, the Brown-Sequard syndrome will present with an upper motor neuron lesion below the level of the lesion. And as we know, an upper motor neuron lesion presents with hypertonia and hyperreflexia. And finally, if the lesion occurs above the T1 level, it can damage the hypothalamospinal tract and cause an ipsilateral Horner syndrome, which presents with ptosis, anhidrosis, and meiosis. And this takes us back to our previous lecture, when we said that the hypothalamospinal tract descends from the hypothalamus to the lateral horn of T1 and then goes up again to the level of the carotid bifurcation at C4. So basically, anywhere above the T1 level is a place where the hypothalamospinal tract could get affected. So in addition to the findings we mentioned, if the lesion occurs above T1, the patient may also present with Horner's syndrome. So to quickly recap, the Brown-Sequard syndrome is a hemisection of the spinal cord that can be caused by a compressing tumor or trauma, and it can present with findings at the level and below the level of the lesion. At the level of the lesion, it presents with motor and sensory affection. The motor affection involves the damage of the corticospinal tract and presents with a lower motor neuron lesion at the same level and ipsilateral to the lesion. The sensory affection involves the damage of the spinothalamic tract, which presents with a loss of pain and temperature ipsilateral and on the same level of the lesion, and involves the damage of the dorsal columns, which will present with a loss of fine touch, pressure, vibration, and proprioception ipsilateral and on the same level of the lesion. Below the level of the lesion, the motor affection is represented by an upper motor neuron lesion. The sensory affection presents with a loss of fine touch, pressure, vibration, and proprioception ipsilaterally, and a loss of pain and temperature contralaterally. And if the lesion occurs anywhere above the level of T1, there could be an affection of the hypothalamospinal tract, which can present with an ipsilateral Horner syndrome. The next spinal cord lesion we have is the poliomyelitis. Okay, so that's a simple one. Polio meaning poliovirus, and myelitis meaning a spinal cord inflammation. So the poliomyelitis is basically an inflammation of the spinal cord caused by poliovirus. Poliovirus is part of a group of viruses called the enteroviruses. It's transmitted through a fecal-oral route and then replicates in the oropharynx and small intestine. After that, it leaks to the bloodstream and reaches the CNS. Once it reaches the CNS, it causes a bilateral, asymmetrical, and irreversible damage to the lower motor neurons in the ventral horn of the spinal cord, usually at the lumbar levels. The patient's findings represent a combination of a viral infection and a lower motor neuron lesion. So the patient will present with signs of infection, such as malaise, headache, fever, and nausea, and will present with lower motor neuron signs, such as flaccid paralysis, hypotonia, hyporeflexia, and muscle atrophy. And in severe cases, there can be an affection of the diaphragm, which can lead to respiratory failure. The virus may also reach the meninges, which are the coverings of the brain and the spinal cord, causing aseptic meningitis. Septic meningitis represents bacterial causes of meningitis, and aseptic meningitis represents viral causes of meningitis. And if we insert a needle into the spinal cord to take a CSF sample in what we call a lumbar puncture, we can differentiate septic from aseptic meningitis. Both will have elevations in white blood cells and proteins, but we can differentiate them from the glucose level in the CSF sample. In viral causes or aseptic meningitis, there will be no elevation of glucose because viruses are non-living things and they don't use glucose for metabolic activities. Bacterial causes, on the other hand, will demonstrate a reduction in CSF glucose because bacteria are living things and they use glucose in their metabolic activities. So, in our case with polio, the CSF findings may show an elevation of white blood cells and protein with no change in glucose levels, because this is a viral cause. So to quickly recap, poliomyelitis is a spinal cord inflammation caused by poliovirus. Poliovirus is a virus from a group called enteroviruses, and it gets transmitted through a fecal-oral route and replicates in the oropharynx and intestine, before reaching the bloodstream and going to the CNS. Once it's in the CNS, it causes a bilateral, asymmetrical, and irreversible damage to the lower motor neurons of the ventral horn of the spinal cord, usually at the lumbar levels. The patient findings represent a combination of infection and a lower motor neuron lesion. So the patient will present with signs of infection such as malaise, headache, fever, and nausea, and will present with lower motor neuron signs such as flaccid paralysis, hypotonia, hyporeflexia, and muscle atrophy. And in severe cases, there can be an affection of the diaphragm, which can lead to respiratory failure. The virus may also reach the meninges, causing aseptic meningitis. Septic meningitis represents bacterial causes of meningitis, and aseptic meningitis represents viral causes of meningitis. And if we do a lumbar puncture, we can differentiate those two types of meningitis. Both will have elevations in white blood cells and proteins, but we can differentiate them from the glucose level in the CSF sample. In viral causes or aseptic meningitis, there will be no elevation of glucose, and in bacterial causes, there will be a reduction in CSF glucose. And in the case of poliomyelitis, which is caused by poliovirus, the CSF findings may show an elevation of white blood cells and protein with no change in glucose levels. Now on to the third spinal cord lesion, the spinal muscular atrophy type 1 or the Werdnig-Hoffman syndrome. So before we talk about the spinal muscular atrophy, just know that we have 4 types. but the most common and severe, and the one you'll get asked about on your exam, is type 1, or the Werdnig-Hoffman syndrome. The idea is pretty simple. Basically, there is an autosomal recessive mutation in a gene called the SMN1 gene located on chromosome 5q, or the long arm of chromosome 5. Chromosomes have a Q arm, which is the long arm, and a P arm, which is the short arm. Autosomal recessive means that the patient needs to receive 2 mutant alleles of the gene to present with the disease. 1 allele from the father and 1 from the mother. So the patient gets an autosomal recessive mutation of the SMN1 gene, which is located on chromosome 5q. Why is that a problem? Well, let's first know what the SMN1 gene normally does. The SMN1 gene stands for survival of motor neuron 1 gene, and this gene helps make a protein called the survival of motor neuron protein. Now, I'll get into more depth of how exactly this protein works in the biochemistry molecular lectures, but for the purpose of neurology and this lecture, just know that the SMN protein is important in the function of anterior horns of the spinal cord, because it forms a complex that can ultimately help in removing introns. Introns are the non-coding, useless parts of the genetic material. So if there is no SMN protein, these non-coding portions of the genetic material will not be removed, and this will cause a dysfunction and degeneration of the anterior horns of the spinal cord. Now you can easily predict how this patient will present. This is mostly pretty similar to poliovirus with a few differences. There are damaged anterior horns, so the patient will present with lower motor neuron signs. But unlike the poliomyelitis, the spinal muscular atrophy type 1 is caused by a mutation and will present congenitally at birth, which is why we call it the infantile form of spinal muscular atrophy. So the patient will be a floppy baby with marked hypotonia and tongue fasciculations. The baby may have a flaccid, frog-like posture. And unlike the poliomyelitis, the muscle weakness will be bilateral and symmetrical. In poliomyelitis, the weakness was bilateral and asymmetrical. Sadly, this condition is pretty severe, and the median age of death is 7 months. The patient may live for a few years at best. Few people can survive this SMN1 mutation though, and we believe it's due to the fact that we have another gene in our bodies, called the SMN2 gene, which produces the same survival of motor neuron protein of the SMN1 gene, but in a lower amount. So this knowledge helped us to come up with a drug that can be used to prolong life in these patients. It's called nusinersen, and it works by alternatively splicing the SMN2 gene to make it produce as much SMN protein as the normal SMN1 gene. The next spinal cord lesion we're going to talk about is the tabes dorsalis. The tabes dorsalis is a spinal cord damage caused by a bacteria called the Treponema pallidum. Treponema pallidum is a spirochete, or a spiral-shaped bacteria. It can be acquired by a variety of routes, including sexually or during pregnancy. The disease caused by Treponema pallidum is called syphilis. Syphilis has 3 stages, from mild to severe. We're going to get into more details regarding those stages in microbiology, but for the purpose of our lecture, just know that an untreated primary syphilis can progress to secondary syphilis and ultimately tertiary syphilis. Tertiary syphilis is also known as neurosyphilis because it affects the nervous system. One of the late manifestations of neurosyphilis is the tabes dorsalis. Tabes dorsalis is basically a progressive bilateral degeneration and demyelination of the dorsal columns and dorsal roots, more commonly at the lumbar levels. Alright, so let's look at the spinal cord cut section. Those are the dorsal roots, and because we're in the lumbar levels, we only have one dorsal column, the gracilis tract, which is responsible for feelings of fine touch, vibration, pressure, and proprioception from the lower half of the body. So because there is a degeneration and demyelination of the gracile tract dorsal column, The patient will present with an altered sense of vibration, fine touch, pressure, and proprioception in the lower limbs. And the altered level of lower limb proprioception may lead to a loss of balance while walking. And this brings us to an important high-yield concept called the Romberg test. The Romberg test is a method that we can use to figure out the cause of a patient's imbalance. Balance involves three inputs: vision or sight, equilibrium, and proprioception. The eyes and optic nerve are responsible for vision. The eighth cranial nerve, or the vestibulocochlear nerve, is responsible for equilibrium. And the dorsal column medial lemniscal tract is responsible for proprioception. So the Romberg test is basically telling the patient to stand and maintain an erect posture for 60 seconds with the eyes closed. If the patient loses balance, this is a positive Romberg test. And patients with tabes dorsalis or damage of the dorsal column will have a positive Romberg test. So basically what we're doing in the Romberg test is we're eliminating the vision aspect of balance. Because a patient can have an impaired proprioception, but his or her vision can compensate for that and help with balance. So to make sure, we have to tell the patient to close the eyes. And in the case of a damage to the dorsal column, as is the case with tabes dorsalis, this will lead to an imbalance in the patient. The tabes dorsalis will also present with damage to the dorsal roots. And this will present in three ways. Number one, the patient will present with a loss of deep tendon reflexes. As we said in previous lectures, deep tendon reflexes are formed of a circuit. The muscle stretch provides an impulse to the afferent nerve fibers reaching the dorsal horn. And then from there, an interneuron transmits the signal from the dorsal horn to the ventral horn, and from the ventral horn to the efferent nerve fibers to finally innervate the muscle and cause a contraction. This afferent nerve fibers going to the dorsal horn is the dorsal root. So if the dorsal root is demyelinated and damaged, this circuit will be disrupted and the patient will present with a loss of deep tendon reflexes. The damage to the dorsal roots can present in two additional ways. Let's first remember that ascending tracts go from the object of sensation to the spinal cord and up to the brain. The sensations first reach the spinal cord via the dorsal roots. So a degeneration of dorsal roots may present with a damage to any one of those ascending tracts. The dorsal roots of the spinothalamic tract may be affected, and we know that the spinothalamic tract is responsible for pain and temperature sensations. So damage to the dorsal roots of the spinothalamic tract can present with a shooting pain that may last minutes or hours. And as the damage to the spinothalamic tract dorsal roots progresses and becomes more severe, the patient may start losing the pain sensations in the joints, especially the lower limb joints such as the knee. We need pain sensations in joints as a feedback while walking to protect ourselves from accidentally doing a wrong movement or putting extra pressure on our knees. So losing such pain sensation can gradually lead to damage and instability of the knee joint, which may lead to deformities in what we call the Charcot joint. Another ascending tract that requires the dorsal roots is the spinocerebellar tract, which sends proprioceptive input to the spinal cord and up to the cerebellum, which plays a role in balance. So a damage to the dorsal roots of the spinocerebellar tract will lead to ataxia or imbalance. Now we're going to talk in more depth about the cerebellum in later lectures, but note that the cerebellum is composed of a midline vermis and two hemispheres on both sides, the intermediate and lateral hemispheres. The midline vermis is responsible for controlling our truncal and proximal muscles. The spinocerebellar tract travels through the spinal cord to the vermis of the cerebellum. So a damage to the dorsal roots of the spinocerebellar tract will present with a disrupted control on the truncal and proximal muscles, which will lead the patient to open up his legs widely as he's walking to prevent himself from falling, in what we call a truncal wide-based ataxia, or a tabetic gait. And finally, Tabes dorsalis may present with a demyelination and damage to the pretectal nuclei, which is a heavily myelinated structure in the dorsal midbrain, which plays a role in the pupillary light reflex. The pupillary light reflex is the reflex in which your pupils constrict when you shine a light in your eyes. And we're going to talk about it in more depth in the cranial nerve lectures. So patients with Tabes dorsalis may also present with a loss of pupillary light reflex due to the demyelination of the pretectal nuclei in what we call the Argyll-Robertson pupil. So those were the first 4 spinal cord lesions that you need to learn for your USMLE Step 1 exam. I hope they were clear and easy to understand. And if you like the content, don't forget to subscribe, and I'll see you in the next lecture.